let's get started. Thanks, Vic, for that. So thank you everyone for coming. And we've got not just me, but our whole clinical trial team here in the front row. So everyone will be sticking around for the whole of the session. So if you've got any questions and answers for our whole team as well, that'd be great if you can kind of keep some of them to the end, and we'll take some questions through the end. So today we're just going to share some information with everyone about these trials that are currently running. As Vic has explained, we're really excited to be able to run these trials here in Victoria. For many of the trials, it's the only opportunity, I guess, for Victorians to participate in some of these trials. And for most of these trials, they're actually world-first clinical trials. So we're able to kind of be on that forefront of treatments that, for the first time, we can actually see if they work or don't work in the context of this. So before I start, just wanted to introduce our teams. You'll see them in person here. But everyone here has been so pivotal in being able to run these trials. Before running any of these trials, we weren't really aware of the amount of workload that comes along with running the trial, I think it's fair to say. So there's no timestamp on the photo of Michelle with those urine screens, but that was like 6:30, and that's kind of 6:30 in the evening. That's what Michelle's doing. So this is a standard sort of day in some of the clinical trial days. It really requires quite a bit of work and coordination, I think, and really sort of passionate and empathetic clinicians who can kind of stay with people through that whole journey. Most of these trials about 14 to 20 weeks, and they require a lot of the participants of having to come into the sites multiple times a week in some cases. So everyone needs to be sort of available, accessible on the phone, both for the participants but for each other as well. So it's been really great to be able to do this, I think, here. And that's putting it in context. So all of these trials are multi-site clinical trials. So we're not even on this map. So most of the sites, and to date, most of the clinical trials have largely been run out of Sydney. And most of the clinical sites are in Sydney for most of these trials, with the exception of NICE, the N-acetylcysteine trial. So these are some of the investigators on the other sites, including some people who have worked here at Turning Point back in Fitzroy. So Nicola Zeres and Adrian Dunlop, who've been here in the past. Also Rebecca McKeaton, who's a professor over at in Perth, who's the lead investigator for the NICE trial. And we've also got Nadine Izad, who's the lead investigator for Lima. So, this really kind of puts in context as well the vast cast of people who has to come together to be able to run one of these trials, because there's so many different sites, there's so many different ethics boards that we need to go through and governance committees that we need to kind of get processes in place through. And those are all really important to be able to protect the rights of participants who go through the trials and make sure they're conducted ethically, but also generate a lot of workload and paper load. So it's just great to be able to see that come together in a drug and alcohol space, because it's probably one of the first times we've been able to run trials of this nature and this capacity across Australia in a drug and alcohol space. In terms of Turning Point, these are the trials we're currently involved in and the ones I'll speak about today. We'll start off with opioids and then we'll move on to methamphetamine. The opioid space is interesting because we've had medications in that space for quite some time. Whereas when we come to methamphetamine, that's where we're still looking for that elusive medication that will really help people get better. So where do medications, I guess, fit into the addiction treatment space more broadly, sort of putting this in context? What I would, I think, like to say is, I guess, from the clinical trial team perspective and certainly from a Turning Point perspective, this is where we might see medications fit into the continuum of treatment. We certainly see sort of medications being available to offer effective sort of engagement in treatment. And the treatment is really a continuum of a whole range of different needs that someone might have if they have a substance use disorder. So that might include, I think, really helping the person being able to engage with the obvious things like a roof over their head, or being able to get food, being able to get safety and security. If someone's kind of caught obviously in a cycle of maintaining that addiction, they might not be able to actually engage in any of the other supports available. So for some people, medication is an option that actually helps them engage in the other sort of treatments. For some people, they might not be ready to engage in some of the other treatments, including counselling or psychological therapy. So it helps someone actually sort of start that process, and it might be a longer term journey for them. So in that context, I guess it's interesting in a reflection of how Australia fits into this in comparison to where a lot of this data is generated in the US. They have clearly a very different sort of social and cultural background and a very different health sector. These images are from the NIDA website, and historically, actually not that historically, until very recently, opioid treatment was called medication-assisted treatment in the US. In the context of the opioid crisis that they've had, there's been a push to move that to just calling it medication treatment. So it's an interesting reflection, I suppose, certainly from a medical perspective and from a doctor perspective. It's an interesting reflection on the need to justify that medications have a space in a treatment paradigm. that they can offer something alongside a whole range of other sort of treatments. Putting it in context as well, addiction treatments and certainly opioid use disorder treatments like methadone and buprenorphine are effective, and they're just as effective for long-term illnesses, for instance, in comparison, diabetes or hypertension or asthma. The recovery rates here are really comparable to other diseases. And that's the disease model, I suppose, that the American sort of system looks at. So this is actually putting it in context and saying people do actually get better from substance use disorders if they can actually engage in the treatments that are available out there, medication included, but also the whole spectrum of treatment. So that's kind of a plug for medications and how they might actually fit in. The problem is we have few medications to offer our patients, and one space where that's been a little bit different is opioid use disorder. But we know that the current treatments that are currently available can be really onerous on people. They require people to do a lot to be able to actually engage in treatment. In Melbourne and in Australia, and generally, we have a relatively low threshold model in terms of being able to get into treatment. We don't require, for instance, people to engage in a whole range of other things. In some parts of the US, for instance, people do need to actually sign in and out of attendance at a whole range of different programs in order to be able to get their medication treatment. And here in Australia, that's not the case. If someone's actually ready to and able to engage in medication, they can do that and can come into treatment when and if they feel like it. So in that context, the gold standard for treatment has been methadone and buprenorphine, opiate agonist pharmacotherapy. And there's decades of literature to support that it actually decreases mortality and decreases morbidity, including sort of HIV prevalence and Hep C prevalence. But several limitations still exist in that space. Daily dosing, as no doubt any clinician who works in drug and alcohol knows that this is a huge barrier for a lot of people. If you have a job, for instance, or if you have family requirements, you need to drop off and pick up kids, etc., it can be really difficult to do daily dosing. The other thing that's clearly a problem there is if you live in a rural or regional setting, there might be one pharmacy that actually can dose and can provide that medication for you, and you might be driving 1 or 2 hours a day to be able to get that medication. So that's a really unique sort of setting where we wouldn't really accept, I think, that sort of model for many other areas of healthcare. That we have a treatment that's effective and available, but you do have to travel 2 hours a day, and you have to travel every day to be able to access that. So that puts a lot of people in a really difficult space. And I think that brings us to that last point. Also, stigma it plays a huge role in that. And again, if you live in a rural or regional setting, you might be dosing at a chemist where everyone else in the town also goes to that same chemist. So there's no real way for you to actually protect your privacy or confidentiality within that space. You'd be queuing up in a line in order to be able to get your dose in the same space as your child's school teacher or anyone else in the community. So that can be really difficult too. So for many people who work in this space, long-acting injectables have been talked about for a little while, and we've been all very hopeful that this might be a little bit of a new game changer, essentially. When I say a little while, probably for about 10 years, this has been on the horizon, but formulations haven't necessarily been available. It's a very quick snapshot, and you need to read through it, but this is an American slide that actually goes through back in 2014 what the different options were available. Now this is 2014, now 2019, 5 years down the track, we've got many more new formulations in comparison to that. And here in Australia, this is what the landscape looks like. So I've put on there as well medications that are available for opiate use disorder that we don't have access to in Australia. So in Australia, for instance, we're all familiar with methadone and buprenorphine and Subutex or sublingual forms, Suboxone. And those have been available for a long time. Now, long-acting injections that we're talking about today are Buvidal and Sublocade, that's the brand name for them. And they are on the market possibly this year. So I'll talk a little bit more about what that means specifically, but the trial that we're talking about is of Buvidal, which is a medication that's gone before the TGA and been approved. We're still waiting to hear when exactly it'll be available to everyone on the market and at what cost and price point. Sublocade is still not available in Australia outside of clinical trials. So there are also other formulations here with the X's on them that aren't available in Australia but are available elsewhere in the world. That includes the buprenorphine implant called Probufin. I don't know if anyone's familiar with it or seen it, but the implant of that basically is quite different from a long-acting injection. The injection actually just goes in under your skin layer and it dissolves over time. The implant sits there and is quite obvious and you can see it, and it has a number of rods that slowly produce the medication. So they're quite different formulations. The thing with the implant is it's a 6-month implant, quite different in comparison to most of the other medications. And if you go down that spectrum at naltrexone, we have oral naltrexone. We still have not gotten a long-acting injection version of naltrexone, which is Vivitrol, which is available in the US. And then there's an implant formulation, which has been available in WA off-label, so it's not a medication that's been approved or available more widely. It's been produced by a company in WA and has now gone into some trials in the US for more study to assess whether it can go before the FDA and then potentially down the track TGA. So that implant is 6 months available. Any questions before we keep moving? So this is the stuff we're going to talk about largely today, the long-acting injection formulations. And in terms of the approved products that are available, this is a really new space, and there's lots and lots of literature that's coming out really in the last couple of years around comparing what are the differences between these medications, which ones are likely to work for whom. And that's really the space where I think our trial team has been really interested in. How do we figure out which patients are going to actually benefit from these versus who's not necessarily going to benefit from them? So that gives you a bit of a spectrum of when these medications have been approved. And these American data show you also how much this costs in the US, which I think you'll all agree is not insubstantial. This is per month. So if you go down, the last medication, the Sublocade depot, is up to $1,500 a month. So that's a lot of money. And so certainly for our patients within our own trials, we wouldn't foresee our patients being able to afford something like this, or most people for that matter. So I think that's a very different space, and this is the comparison here where we're really interested to see how this will work in an Australian health sector with very different sort of pricing points and also delivery of care with universal health care, how that will actually work in terms of these sort of medications. Neither of those medications, Sublocade or Buvidal, have an actual price point yet in the Australian market. So we don't know how much the PBS is willing to completely subsidise and how much it will actually cost to the consumer at that point. Just give you a bit of a sense of the numbers of sort of publications that are coming about. The top two have really only come out, I think, in the last couple of weeks. That one's actually last week. So there's a number of these things that are constantly coming out in terms of people reporting their experiences of being involved in trials, participants talking about whether or not they've, their own experiences through the trials, and clinicians trying to get their heads around how will this fit into the health sector. In Victoria, we have quite a different model compared to the rest of Australia, in the sense that everyone who comes in for opioid use treatment, methadone or buprenorphine, doses at a community pharmacy. There are no dosing points in Victoria that are actually hospital-based or health system-based. So that's a very different model from, say, New South Wales and some of the other treatment settings in Australia. And that has an impact on how that medication is delivered, how the Department of Health produces permits, how doctors have permits, how they actually get the medication. I said as an injection medication, it can't actually be available generally in a pharmacy in the same way the current models are, for obvious reasons that there isn't usually someone at a pharmacy that can administer an injection. There are a small number of pharmacies that do have someone who can administer, but that's a really small number in comparison to the landscape. So this is all really new for us in the health sector in Victoria, and it's certainly new for the Department of Health, who are currently working through guidelines around this. And it's really new for the pharmacy sector and the general practice sector as well to try and understand how do they actually move to this and being able to offer it. In terms of our perspective on it, and particularly in the trial as well, I think we've been really keen to be in this trial because we hope that it can offer convenience and freedom for people that they don't have to actually attend every day. And it might be really helpful for people who are wanting to engage in work or live in rural or regional settings. It might also work for people on the other end of the spectrum who aren't stable, who are really struggling to get into a pharmacy every day or maintain in a program. It might offer an alternative, especially the medication options that are weekly and monthly, which give you that flexibility of trying to come on and come off treatment as well. We're hoping that also will allow sort of reduction in stigma because you don't actually need to go into a pharmacy to do this. And hopefully then we can also have more of a debate with people about the centrality of that medication in their lives. For most people who say are on an oral contraceptive pill and blood pressure medication, for most people you might remember to take it every day, but that's the only time that day it might have an impact on your life. For people who are daily dosing of methadone and buprenorphine, it's a very different paradigm. Obviously, much of your day can actually be about that medication. So for some people, that sort of fit and forget, that inject and forget sort of paradigm might actually work reasonably well and might actually change that centrality of both their medication but also their substance use disorder within their lives. And we've also had debate with people who are coming into treatment about whether that centrality and taking that away from someone, how will that actually work for that person? Is it important for that person to go into the pharmacy actually every day? Is that structure and that routine actually really helpful? Is that the only social aspect that some people have in their lives? And so people have talked to us about that as well. So it's really interesting. It's a new space, and I think both our participants and us haven't really got our heads around that, but we've also heard some really interesting stories. The question for us is this a game changer, and how will this fit into our Australian healthcare system, but also the Victorian healthcare system? And we're really keen to have questions and discussion in the audience later on about this as well. So just taking you through the trial itself, we closed recruitment a while ago, and we've just had 3 people now finish up on the trial. And we had our first person today go into the post-trial injection phase. So people are actually finishing up at the moment, which is really interesting. The long-acting injection that we're using is the one called Buvidal on the left. And to date, it's had 7 international multi-site trials. So it's been tested fairly thoroughly in humans. And also Sublocade, which also has a range of different sites currently recruiting into their own trials as well. Their trial is called CoLab. It's a great acronym, so Debut and CoLab are the 2 trials currently running. So in terms of the formulations, these are both slow release, the subcutaneous injections, and they deliver the dose either over a week or over a month. So the Buvidal formulation comes in both the week and the month. And if people are interested, there is a paper on how that actually works in terms of the how it's released in the system and how slowly or quickly it comes out. But in essence, the medication is exactly the same as what's in Suboxone. It's buprenorphine and naloxone. It's what we've used for a long time, but the formulation is what's different now. So for both of those medications, the formulation is quite different in both the Buvidal and Sublocade. And it's about this gel sort of crystal formulation that goes in and sits just subcutaneously, just under your skin, and then slowly comes out over the next 4 to 6 weeks. So we've had a variety of different experiences of that in the trial itself. We've had people where as soon as we put it in, and people can't feel anything at all, and if you don't even know it's there. And then we've had some people where you can kind of feel a little palpable lump there that slowly, interestingly, seems to disappear over a month or sometimes 2 months. So we've had lots of experiences going, okay, we'll just have a touch and see if, is it any smaller? And people can tell us, oh, it seemed to disappear after 3 weeks or 6 weeks. So it's really interesting. It varies from person to person in the site that we've been using. Within the trial itself, we've rotated different sites. So we're trying not to use the same site at the same time. But, it really isn't something that, say, for instance, if you had the injection under your skin, that anyone could see or tell that you were having. So that's quite different from the implant formulation I was saying before. That's very obvious that you have that under your skin. So this is the name of the trial, and we expect that, so all of the sites are closed recruitment. Most of the sites have now finished to some extent. So by the end of the year, we'll probably have more information in terms of more results that will probably come out in a publication. And at that point, this particular trial is really not looking at safety or efficacy, because they already know that from the 7 trials they've done. What this trial is about is understanding sort of treatment satisfaction, quality of life, and also how this actually works in the Australian market. This company is new to the Australian system. Its competitor, which is the Sublocade provider, Indivior, they produce Suboxone, and they've been around obviously in Australia for quite some time. So for this company, this trial is also a way for them to understand how the Australian treatment system works, understand how they need to market their product. For us, it's an opportunity to see what a weekly and monthly formulation might look like, because the other product doesn't come in a weekly formulation. It only comes in a monthly. So this is what the trial has been looking like, and cheers to Vicky for making, well, many of these slides, but this one in particular. So this, essentially, it's a randomized trial. It's not placebo-controlled. We know what the person's on or not. And people either get the injection or they get the Suboxone. We all had a very emotional start of the trial where we were all waiting at the computer to see what each person would get. And we had an opportunity where many people in our trial originally got standard care, which was Suboxone. So lots of people come in going, am I going to get the injection? No, you're not. And we have no way to actually influence that. At the end of the trial, the good news is that at the end of the trial, everyone who's been in our trial gets the opportunity to then go on to the injection. But during the trial, we've had 50-50 essentially through the trial. The site that we've got here has got just about 20 people all up. We've had some people drop out along the way. And along the other sites, we've had South Australia and then 4 New South Wales sites. And as I was saying, it's not about efficacy or safety, it's about feasibility and satisfaction. We've had some interesting conversations with people who've really said that it's changed their lives in some circumstances, largely because they haven't had to go into a pharmacy, and so the time requirement of that has been really great. For some people, and we've had a really great opportunity of recruiting some people who've come to us after going to the injecting room actually down the street from us, and who wouldn't otherwise necessarily have considered Suboxone as a treatment or buprenorphine as a treatment otherwise, because of the threshold required to be able to engage in treatment of needing to go in every day. Some people had jobs they needed to get to or needed to travel. That's the other big thing here around travel. So people really couldn't see themselves getting to a pharmacy every day. So this has been really an opportunity for some people to do that, and we've had the reflections where people have said that's been brilliant, that they've actually been able to see what that's been like. So the trial itself has been 24 weeks, so we needed to have people agree to be on it for at least those 24 weeks, and then post those 24 weeks make a decision about whether they wanted to continue on the injection or on Suboxone, or if they wanted to potentially come off treatment altogether if they felt like things had actually moved on for them. So that's the last slide on the buprenorphine one. I'm going to move on to methamphetamine. And when we move on to methamphetamine, we've got two trials to talk about, lisdexamfetamine and N-acetylcysteine. We've also got Ramez as the primary researcher on N-acetylcysteine, who'll talk to us a little bit about his own experience recruiting into the trial, but also people's experiences in the trial so far. And that's the trial that's been running the longest here at Turning Point, so we've got the most reflections from that trial. So in terms of methamphetamine, not news to anyone that whilst in the population level, the rates of prevalence of methamphetamine use have been fairly stable for the last 5 years or so. Conversely, people who have got a dependence or use disorder, that's really been going up and up. And really our understanding is that's been related to a shift in use from speed, which has been less potent, over to crystalline ice, which is much more potent and associated with a whole range of other harms. So because of that, we've seen this increase. Because of that, we've also seen treatment episodes within treatment sector across drug and alcohol. That's actually doubled over the last 5 years. So people who are actually coming and seeking treatment for methamphetamine are now the second largest group of people who are seeking treatment at all in our system. Which is an interesting reflection, because I think if you work in the treatment system, we all know that alcohol is by far and away what people come to treatment for. So for methamphetamine to start creeping up that league table essentially and be up there in terms of a primary drug of concern really highlights how much of a problem this has become for people. So most people seeking treatment for meth use will have community drug treatment services, so we'll be able to access counselling or psychosocial treatment. And we know that for many people that is actually very effective compared to people, for instance, of an alcohol use disorder. We know from the patient pathway study that was conducted here, from work from Victoria and from Dan, has really kind of highlighted that compared to other sort of substance use disorders, treatments such as psychosocial treatment, residential rehab work really well if you've got methamphetamine use disorder. But people often struggle to maintain that treatment, maintain that improvement in recovery longer term, for instance, post-rehab. And also there is a group that might really struggle to engage in treatment at all. We know there's a big treatment gap for methamphetamine, so in the population we know that there are many more people who use the drug and have problems with it than there are people who actually front up to treatment services. So that's the space where both of these medications we see as having a role. So they're quite different medication treatments. Lima, which I'll talk about first, is an agonist treatment, a stimulant treatment, and it was designed really for people who are on one end of the spectrum who use a lot and who have tried different treatments and haven't actually found that they've been effective. On the other hand, when I talk a bit about N-acetylcysteine, which works through different mechanisms, not a stimulant agonist, N-acetylcysteine is more aimed at people who haven't really wanted to engage in treatment, haven't actually walked into counselling treatment, haven't tried resi rehab. It's for people who like to reduce their use but having difficulty actually engaging in treatment at all. So pointing out why these medications might have a role, our treatment guidelines came out early this year now and available for download on our website, and some of these next images come from there. I think what we really highlight is, compared to many other drugs, methamphetamine withdrawal lasts for more than the 7 days that a standard detox does. And then that withdrawal phase and that early recovery phase can still have problematic symptoms for up to 3+ months. So we know that people, even if they manage to kind of attend and complete a detox, are still struggling for a period of time. And that's usually struggling outside of a detox setting, so outside of a residential setting. And so that's why people can really struggle at that early phase to maintain that recovery. because they're struggling with a lot of symptoms that ordinarily would have been improved by using methamphetamine. For instance, problems with sleep difficulties, problems with insomnia, for instance, energy levels, anhedonia, or difficulty getting pleasure from activities, depressive symptoms. So that's the phase where people actually start to often relapse. And so in terms of medication treatments that have tried to address this space, and this is from our treatment guidelines if people want to go off and read up about it, but looking at the stimulants, which are in the second category over there, there have been lots of trials of stimulants to date. The lisdexamfetamine trial is the latest, but it's certainly not the first. And this comes from a background and evidence base for methadone and buprenorphine in opiate use disorders, where we know opiate agonists work really well for opiate dependence. So the idea there is really that a stimulant agonist on face validity, on just looking at it, should work really well for stimulant dependence. And really the evidence to date hasn't borne that out. In the clinical trial settings, people don't seem to actually be able to engage in treatment or reduce their use within the context of a stimulant agonist trial. And that's included a whole range of things, but many of them have also included short-acting medications and then sustained-release medications, such as methylphenidate, or Ritalin, and dexamphetamine, sustained-release. So where do we come to with the Lisdex trial? I think the evidence to date, when you look at the clinical trials that have been done, the question has really been raised in terms of dosing. Have the doses in these trials been high enough? Knowing that people who use methamphetamine potentially daily, they might have quite a different tolerance to what we might expect, and that might not actually be borne out by the doses that are used in the trials. The dose might not be enough. Next question is around dropouts in these trials have been high. So across all of the trials, the dropouts are between 40 to 50%, which makes it very difficult then to make any meaningful statement about differences between two groups in placebo trials. That is a reflection potentially of the first thing, whether the dose wasn't high enough, but it can also be a reflection of the fact that people usually know if they're on an active stimulant quite quickly in the piece when they're in a trial. So if they go into a double-blind placebo trial where you don't know what you're going to get, and in the first week you're on medication and you're taking it every day, if you don't get an effect in the first week, it can be very hard to require the person to keep coming in every day through the course of the trial. It's certainly something we've reflected on lisdexamfetamine already. So it can be really hard to maintain that engagement and say, we need to get this evidence at the end of the trial. It sounds like you think you're on a placebo. We don't know. You don't know. But, this is a 14-week trial, and we won't be able to say yay or nay until the end of the trial. So that can be really difficult. Most trials have also to date been about 14 weeks or less. And so the timing of that can also be problematic. We don't know what the evidence base is for longer term recovery in this space either. So lisdexamfetamine, the website's there if people want to read up about it, and people can self-refer into the trials as well. So if you have any clients or anyone else who's interested that you know of, they can just refer themselves in as well. This has had a lot of press since 2014 and then subsequently, because it was studied first in an initial pilot in Sydney, which had some media coverage, and then subsequently the bigger trials have also had some media coverage, somewhat stigmatizing media coverage. In terms of the study itself, the background of the study included the pilot, which was really done within the stimulant clinic in Sydney and St. Vincent's, which was with a group that was using very heavily, so almost every day, who might have had struggles with housing, employment, a whole range of psychological and social difficulties. So the idea behind this trial is if it works as stimulant agonist for this group, this heavily dependent group, then it should potentially also work for other people. But certainly if it works for this group, then this is the group that really might benefit from medication intervention at all, to be able to engage them in the whole range of other interventions that are available. So the trial has been running for about a year at the other sites, and Turning Point is a site from this year, so is Royal Prince Alfred RPA in Sydney. And so we've come on just this year, and we're the only trial site in Victoria. So the aim of the study is to look at whether the medication is effective in reducing use, reducing cravings and withdrawal symptoms. It's randomized, it's double-blind, and it's placebo-controlled. So that's something that I know Rowan and Tamika spend a lot of time on the phone talking to people about. To get it as placebo-controlled, and we don't have any say in being able to assign people to either group, and it's also double-blind, so we can't tell and you can't tell what you're on. And once you get into the trial, you can't switch arms either, so that's a really difficult discussion, and I think at that point as well, there are many people who choose to not opt in after that. One group obviously gets lisdexamfetamine, the other group gets placebo. Everyone has the opportunity to engage in counselling, and here that's a 4-session CBT model that's been previously shown to be effective. The participants, clinicians and researchers don't know which group they're on. And the two groups are compared right at the end of the trial. And so the aim is to get 180 people. So slow going and hard going to try and get across all of those sites. And partly that's because of a few things I'll talk about. So this dexamphetamine, as I've explained, there's not a lot of evidence of stimulant agonists to date, but a range of features suggest that this drug might be more effective than some of the other medications. It's a long-acting stimulant, and it's a once daily formulation. So if it's effective in this trial, what that means is after the trial, people might be able to go into a chemist once a day and get it. They don't actually have to go into a chemist twice a day and get it, which would be very problematic. Also, once daily means that there's less abuse or diversion potential. So if the person takes that medication once a day, they're not going to have a takeaway potentially that could be diverted, because we have to remember it's an active stimulant. There's a slower onset of action and a longer duration of action compared to some of the other trials of dexamphetamine in particular. And again, because we'll show you in the next slide why it has less diversion abuse potential, because the medication is actually converted to its active drug, dexamphetamine, within the bloodstream. So it's a prodrug of dexamphetamine in that sense, and it's converted within the body. So crushing it or doing anything to it outside of the body won't actually release the dexamphetamine until it's actually injected or used. So peak concentration here in this space is about 3.5 hours after the dose. So if people actually come in and have the dose, they expect to have some effect about 3 hours later, and then it lasts for up to 12 hours. And it's once daily because of that. There's a whole range of potential side effects that are associated with this, which obviously a whole range of effects that are associated with any stimulant, including methamphetamine. This is why we have to be really careful in this trial, and why our team spends hours doing lots of pre-screening and screening measures. It's really to make sure that this medication is not going to trigger sort of severe adverse effects for people, particularly people who might already be vulnerable. The big things here are around people who might have any cardiovascular risk factors. So anyone who's had any sort of cardiovascular risks in the past, so any heart attacks, any high blood pressure, those sort of things. So we invest a bit of time in kind of screening for that. And people who've got severe sort of unmanaged mental health problems, we still see people who have mental health problems in this trial. So really interestingly, it's not a trial that has a whole list of exclusions around a whole range of disorders. It is a trial that pragmatically does try to include people who've got mental health problems, as long as they're somewhat managed mental health problems. And so, for instance, if there's opportunities to help the person manage the mental health problem before they come into the trial, then we try to do that as well. The study involves randomization and double blinding, and it's actually lisdex or placebo, which this is a big thing. It's daily at the start, so daily supervised, requiring people to come into this site once a day for that first week, 5 days. So that's a big ask for most people, and that's the part that for most people we pre-screen becomes difficult. Interestingly, I think some of the Sydney sites maybe have less of a difficulty around that because they're not the only site and they're recruiting for quite a number of different areas. But I think for some of our participants are still doing this and coming in 1 hour each way and doing that 5 times the first week, and then twice weekly after that. So it does drop off for the rest of the trial. It's that first week that's really intensive. And then there's monthly research interviews. Those interviews for the medication visits are very short, so they're like 20 minutes, half an hour. But those research interviews are longer. And then that's 14 weeks with attendance here at this Richmond site. So in terms of exclusion-inclusion criteria, they're fairly broad, as I was saying, but unstable or unmanaged mental health problems, unstable substance use, this is entirely the judgment of the investigators. So we don't exclude anyone who's using just anything else. People who are using OSTs of methadone and buprenorphine aren't part of this trial, so that is an exclusion. But any other sort of substance use treatments are fine. Also a range of cardiovascular illnesses, as I talked about. And that's okay, I'll take the question if you like. Yeah.
Just about pregnancy.
Yeah, no, that's people need to not be pregnant. They need to not be pregnant, but also we do pregnancy testing through the course of the trial, and people need to agree to use contraception as well. Yeah. But it's not, safety hasn't been shown in pregnancy for this trial. And inclusion criteria, obviously methamphetamine dependence, and really more on the severe end, as I was saying, and have tried something in the past in terms of treatment, any type of treatment, counselling, rehab, even if it's been 10 years ago, we'll consider that. But it's really about for people who've tried other things that we know are evidence-based and haven't worked for them. So if you're interested, that's the website, that's the email address, drop us a line, and we can talk through questions around that. Next one, nice. And so we'll be co-presenting this, myself and Ramez, around this, and I'll take you through some of the background and then hand over to Ramez, who's been, the frontline person across this trial. This is a world first trial around N-acetylcysteine. And people might have heard about N-acetylcysteine. Certainly in the medical field, doctors know it as what you give people if they've got Panadol poisoning in an emergency department. More recently, so that's an intravenous infusion in ED, more recently it's been trialled across a whole range of different disorders, including a whole range of mental health problems, with the idea that it actually might restore sort of balance or homeostasis in the brain across a range of different mechanisms, mainly to sort of dampen down sort of excitation in the brain. I'm really bring this down to a level that I understand, many people can understand, but it's really complex literature. We don't really understand why it works or how it works for many different substances or illnesses. But this is really kind of one of many trials that are currently being run around the world to look at how this might work. It's a big trial team across Australia. And there are a number of different people who work at the site, but also there's a site in Geelong who's also recruiting, so there's 2 sites in Victoria, and then there's a range of other sites across Australia. And so what is the medication itself, or the substance? It's listed by WHO as an essential medication, as I mentioned, for paracetamol poisoning. It's also been used in cystic fibrosis because it thins mucus. It also can be used in kidney illnesses. It's got a range of other potential uses, and when I say a range, here it's been trialled in lots of different things. It's an emerging evidence-based rather than established evidence-based for any of these things. It's also available as a supplement online or at compounding pharmacies in varying doses. And so it's not approved in Australia, certainly, but it can be used as a supplement. And many of the people who've called, I think, in terms of pre-screening or screening, have potentially read about this trial and tried things themselves. I think the medication that we're using in the trial is quite a different dose from what you could get sort of over the counter or online. In terms of how it works, and I'll skim over this in the interest of time as well, I think, so N-acetylcysteine is a precursor for this medication itself, is a precursor for cysteine, which is thought to have a couple of metabolic roles in the body and the brain. As I mentioned, sort of antioxidant activity, but also particularly through the glutamate system. The glutamate system across a whole range of disorders, so including psychosis and depression, is really emerging as a really important system in being able to modulate excitation in the brain. So the hope is that, in an addiction space, modulation of the system can actually dampen down sort of reward or reinforcement sort of capacity. It addresses a whole range of different types of psychiatric disorders, but these presumed pathways, so impulsivity and compulsivity, which are really relevant for us in the addiction space and in gambling, but also potentially through oxidation in the brain for a whole range of different disorders. And within methamphetamine use disorder, there have been a couple of goes at looking at this. There was a small trial in Iran which suggested that it might reduce use and dependence. It's really hard to make comparisons against that trial and how it might work here. So this is a much bigger trial that we're in terms of NICE. And it also, the question is whether it protects against neurotoxicity. So we know that in people who use methamphetamine long term, that there can be adaptive changes in the brain resulting from that methamphetamine use. And so the question is whether the glutamate system might be involved in some of that in a protective effect, and then N-acetylcysteine might be able to ameliorate some of that as well. So the objective of this trial, and this is a high dose, is 2,400 milligrams in this trial. It's a high oral dose. And the idea is that hopefully it should reduce use compared to placebo, and that's the main objective in this trial is use. And then they're also looking at dependence and dependent severity, craving, withdrawal, and psychiatric symptoms. It's a placebo-controlled trial as well and double-blind, and so they're looking at that versus placebo. The study design is very similar in some ways to some of the other studies we've talked about. It's phase 2, it's double-blind. There are these 3 sites we're recruiting from, the 2 in Victoria and also Wollongong. And the idea was for an 18-month recruitment. We're coming towards, I guess, in the 3-quarter phase of past the halfway point for this trial at the moment. And so that's the aim, to try and get to that 180 across all of the sites. Everyone also gets just this brochure, but you have to remember that this trial is also trying to recruit people from the community. It's not recruiting people who are already in treatment services or are trying treatment and struggling. This is recruiting people who don't necessarily want to access treatment already. So people receive that brochure, but they don't get anything else in terms of counselling within this trial. They don't get what we consider sort of active forms of treatment in that way. and they come in to see a doctor for the medical screen at the start, but then don't have to necessarily see someone medical again in the trial. They do get to see our researchers across all of the sites, and in a fairly intensive fashion. So Ramez will talk a little bit more about that, I think. But when I say that people aren't getting counselling, they are getting a somewhat active treatment in the sense that they're seeing someone who cares about them and cares about how they're going fairly regularly. So we wonder about whether that will influence the outcomes or not. We don't know because it's double blind, but we'll see at the end in terms of how people go. In terms of eligibility, this is, if people are interested as well, just come and see Ramez or I at the end of the thing and we can send you information, and there's the website as well. But inclusion is really dependent and wanting to reduce use, and happy to continue the trial protocol. Exclusion is people who are already in active treatment, who might need mental health care right now, or urgent care for anything else. And then the rest of this medication in comparison to the lisdexamfetamine trial is a fairly inert medication. So we're not concerned about many mental health or medical disorders in comparison to the lisdexamfetamine trial, but there are submedical conditions that might exclude people. The main outcome measures here are self-reported use as well as the saliva sample that we'll be testing at the end of the trial to be able to compare the two arms for amounts of use. There are a range of secondary things that we're all also interested in seeing the outcomes of, including some mental health measures that we're interested in seeing the outcomes of, independence and craving. And so we've got all our details here, but Ramez will pick up shortly and tell you a bit more about the trial. Okay.
Good. Okay, thanks, Shalini. So, I'm just going to briefly discuss a bit about our progress in the trial to date and just some reflections on how things are going from a front-end perspective. As Shalini mentioned, this is a double-blind placebo-controlled trial, so neither the researchers nor the participants know who's getting the active drug. The drug has no real psychoactive properties, which is kind of handy from the trial perspective because the participants really can't tell if they're on the medication. Although some, I think that they have a pretty strong idea that they're on the medication. It's a community sample, so people who aren't in treatment are recruited into the trial. We've been running the trial since July last year, so it's at about the 1 year point. And in terms of data collection, once people are judged as eligible to be in the trial, we follow them up weekly with follow-up assessments, which typically take from 30 minutes to 60 minutes, and they're fairly intensive. As Shalini mentioned, we touch base with people about their substance use, but also about how they've been going throughout the trial, their mental health. It's really kind of a touchstone for them as they go through the trial. As of the beginning of June, across all the 3 sites, so across Melbourne, Geelong and Wollongong, we'd recruited 92 people. We're looking to finish recruitment by the end of November and hoping to have findings available in the second half of next year. Our follow-up rates are decent for this cohort. It's in the range of 60 to 70%. In Melbourne, where we've passed the halfway mark as well. We've had 17 people complete the study. We've had a lot of inquiries, so we were quite fortunate in that we did a media release at the start of the study, and that got picked up across a range of different media organisations that went international. We had TV coverage. We did like a breakfast TV show, I think, in Perth, and that's resulted in a fairly good knowledge about the study across the community, from family members to drug users to treatment providers, which has meant we haven't had to do a lot of advertising. We just have this kind of constant stream of inquiries about the study. I've screened 100 people, but we also have a lot of inquiries where people don't get screened, where a significant amount of people are making touch with us as a first step in their drug treatment pathway, which I think might say something about knowledge around how to engage with the drug treatment system in Victoria. So about a third of people I refer on to Direct Line, just so they can get a better sense around their options. Clearly, we don't know if NAC works or not, and there are already a range of known treatment interventions out there, things like counselling and other kinds of supports like peer support so people can engage in. And so, I end up sending people along to Direct Line, and mostly at that point they won't get back in touch. I thought I'd see just a little bit of data, although it's important to note that these aren't actual findings. So, yeah, this is only data from Victoria or from Melbourne. I've just kind of scraped a bit off our database, but because we're not at the end of the trial, we don't know if this will change. But in terms of the demographics, I think we do have a slightly different cohort to your regular sort of complex treatment-seeking cohort. While the gender split's kind of fairly similar to most treatment-seeking services, I'd imagine, at about 70% male, we have an overrepresentation of injecting drug users and people from a range of diverse backgrounds. So quite a large proportion of our trial are employed. Many are employed full-time. People employed across a range of different areas of the economy. So from people like senior policy advisors, people in the criminal justice system, tradies, all sorts of people, which I think is a bit of a reminder that in drug treatment we often just see kind of a thin slice of the pie, the more complex kind of parts of the community. And I guess, yeah, it's a reminder that most people who use methamphetamine may not even have problems, and most people who have problems may not even engage in treatment. And so we do get this kind of skewed perspective in the treatment sector. We've had, in a sense, a surprisingly positive response so far to the trial. We've had quite a few people do well, more than we would have expected at this stage. Most people are seeking abstinence, although we have had a significant proportion as well, just looking for controlled use. Although there's only really been 2 of the 32 that aren't interested in abstinence if you ask them if they had to choose between those options. Yeah, in terms of the ones who have become abstinent, most people tend to stop using at the beginning of the trial in the first few weeks. And of course we don't know who's getting the active medication, so we don't know why this is happening. Just to reflect on that a little bit, we certainly have a highly motivated sample. This is a group of people who are willing to take a medication that's not known to work. There's a 50-50 chance they may not even get the medicine. And so I think this is something we can't underestimate, this sort of readiness to change factor. As Shalini mentioned, it's not an intervention in and of itself, but in a way it kind of works like a structured intervention. People take a medicine twice daily. Whether or not it works, this is like a daily reminder that they're kind of on this process, on this journey, and they want to affect change in their lives. They meet up with myself and the other researcher, Davinia, weekly, and it's a fairly intensive session, so I think people are finding benefit from that as well. There might be a placebo effect happening there. I mean, we don't know a lot about how placebo works in a mental health care setting. I think a lot more is known in a pain setting, but that could be one factor. I think people's belief that a treatment works seems to play a factor. Those that think they're on the active drug invariably feel like it's working. And of course the social support they receive. So while it's not an intervention per se, just having an empathetic ear, someone to kind of touch base with weekly and reflect about their progress seems to be really helpful. In terms of the feedback we've had from participants, we're not as of yet talking to everyone about their experiences in a systematic way, but I certainly have a lot of contact with trial participants, and on the whole, people are getting involved in the trial for either self-improvement or for altruistic reasons, or a combination of both. Whether or not people have the outcomes they are seeking in the trial, I think largely people are reporting positive experiences. It's either they do get the outcome they're seeking, or they learn a lot about themselves and their substance use. They certainly appreciate the support. And we've been applying for some funding to investigate participant experiences in the trial in more depth. That's about it in terms of the reflections. It's been a really rewarding process for me as a researcher. I think often research can be almost a little bit exploitative. You meet somebody once, you get some data from them, and while that might be a useful experience, any benefit they get from that research might be kind of indirect and down the track. And in this case, I've got to work with people who've made some significant changes in their lives and seen, in a lot of cases, big improvements in their well-being, and that's been really satisfying. Thank you. Oh, yeah.